Good evening, everyone, and welcome to our Orthopaedic webinar. My name is Helene. I'm the Workforce Development Officer here at Westvic PHN. I'll be a facilitator for this evening alongside Jade, who is also here at the PHN. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations people and organisation. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. Jade will got that up in the chat, where you can click on that. So yeah, you can also see our upcoming events on the screen now, and you can register for these through our website, and there'll be also a link in the chat for those. Special mention to our upcoming education dinners for GPs and practice managers in Warrnambool, Ocean Grove and Hamilton, where you can enjoy complimentary canapes and sit-down meal with your colleagues. The registration link is in the chat. Please make note of the Westvic PHN health pathways relating to this topic that's on the screen at the moment. Our PHN will provide a certificate of attendance, so please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, just retype your name, first name and last name into the chat box. That way we can make sure that we get the correct certificate to you. This event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question and answer time at the end of the formal presentation. We encourage interactivity and discussion, so please feel free to type in your questions in the chat box at any time, and I will ask them on your behalf to the presenters at the end. Your feedback is important, so if you could take the time to complete the event survey, and there'll be a link to that also in the chat. Our presenters for this evening are Mr. Andrew Wilkinson, Orthopaedic Surgeon, and Mr. Rob Osborne Physiotherapist. I will hand over to Rob and Andrew now, and we can start the presentation. Thank you.
Good evening, everybody. I'm Andrew Wilkinson. I'm an orthopaedic surgeon based up in Geelong. For those of you that I can see on camera, can I get a little thumbs up to say that you can hear me properly? Thank you very much. So I work at the public hospital and also Epworth and St John's. My interest is primarily in lower limb arthroplasty with a secondary interest in trauma, particularly periarticular knee trauma. I'm very grateful to be here tonight at the Keyser Centre in Geelong with Rob Osborne, one of the physiotherapists here, senior physiotherapist and partner in the centre. We've set the presentation up tonight to try and cover a few things, and I hope that the format of that becomes clear. Really would like to engage with you with questions at the end. Please don't hesitate to ask anything in the chat that you feel along the way.
Thanks, Andrew. Good evening, everyone. My name is Rob Osborne. As Andrew said, I'm here at Keyser Geelong. My background is I've been a physio for near on 20 years now. Initially trained in the UK, as you might be able to tell from my accent. In the UK, I had a background working in National Health Service, in orthopaedic wards, in private practice, in rehab environments for the military and the elite sport. Since moving over here, I've been solely with Keyser for 11 years. Keyser is a strength and rehabilitation centre involving physios, exercise physiologists and exercise scientists, and we have a passion for building the strength of Australians, allowing them to continue doing the things they love as they age, regardless of their health or regardless of their disability. I've known Andrew for several years since he's been a patient of mine initially, and since we've collaborated a lot on treatment of various different patients. And we've reflected on this over time about the challenges that are faced within primary healthcare, about identifying the right pathway for clients with osteoarthritis of the knee. I often see patients who have not engaged with conservative therapy till a long way down the track, or they have engaged with conservative treatment and only to find it unsuccessful because of inappropriate interventions or poor dosages. And I know Andrew has frustrations regarding referrals that he receives from patients who aren't appropriate for surgery or potentially don't want surgery in the first place. What we're going to talk about today is how to identify the patients that will benefit from the interventions we have to offer, and trying to find the right interventions for the right patients at the right time in their journey. So learning outcomes from today, the learning objectives, we want to raise awareness of the 2024 clinical care standards for the management of knee osteoarthritis. We want to talk about the appropriate triaging of patients in primary healthcare into an appropriate pathway for their management. I'm going to elaborate on conservative management of knee OA and exactly what constitutes evidence-based conservative management. And Andrew is going to talk about how knee replacements are a very good surgery and what the advances in surgery are and have been now. So firstly, the clinical care standards update. This is an update from the original clinical care standards, which were produced in 2017. And the aim of these clinical care standards is to improve the timely assessment and optimal management of patients with knee OA and to lessen the disability caused by knee osteoarthritis in the general population. We could just walk you through the whole clinical standards tonight, but it's quite late and I'll probably lose a few of you across the way. If you are interested in looking at the clinical care standards in more detail, there is a QR code on here which will take you to the website where those clinical care standards can be found. What we're going to do today instead is lead you through a series of case studies where the clinical care standards have in some cases been followed very well, and in other cases, there have been divergences from the clinical care standards. And we're going to reflect on what effects that's had on client care. So I'll hand back to Andrew, who'll take us through the first case study.
Thanks, Rob. So we have, and these are all patients of mine. These are real cases. And I think it's quite nice to be able to hang the information about triage and conservative therapy and knee replacement surgery around knee arthritis onto real patients. So the first patient I want to bring to you is a patient I have through Geelong Hospital. She's a 48-year-old lady and she has pain and disability in her right knee. She's got a very limited walking distance. She can only walk about 500 meters at the most. And this is a particular problem for her because she doesn't have a driving license and she can't drive. So if she comes to see me in the clinic, she has to take the train from Colac to Geelong, and she has to walk from Geelong station to the public hospital, which is a lot more than 500 meters. She's on a disability pension, and she doesn't work. And she is quite an honest individual. She drinks 3 liters of wine a day. And the last time I was in the clinic, she was drinking while she was in the waiting room of the public hospital. And so there's a few things that we could have as concerns for this about how do we manage this patient with what is clearly being made as a diagnosis of knee osteoarthritis. And she, on her x-ray, she does have osteoarthritic knees after some injuries in the past. But it then comes on to, well, if we look at the whole patient in a holistic manner, is she suitable for surgical treatment of her knee problem? And I think if we present to you a 48-year-old lady with multiple social difficulties and an active alcoholic history problem, which she recognizes and she's seeking counseling and rehabilitation for that, that's clearly not a person that any of us would think would do very well with an operation. And so this is the first point in the clinical, the quality statement, and it's about a comprehensive, holistic assessment of the person. And I don't think that this goes much more than old-fashioned knowing your patient and a good history and really the kind of things that the general practitioner folks around the Western Districts and through Geelong and Ballarat and Bendigo and Warrnambool probably know their patients much better than the specialists. But this is the person that you're entitled to at the first number of encounters to divert them along a different path, because they're probably not going to do all that well with an operation. So there's a little bit here about the overall patient selection. And then once you've made a diagnosis of osteoarthritis, no matter how appropriate, whether they should come along to a surgeon or not. If we get into the second case, then this is a lady who I've known for quite a long time. I first met this 68-year-old lady in 2018, and she had a little bit of knee pain. Her knee pain was worse with activity. She didn't have clicking or catching. There was no mechanical phenomenon. She hadn't got any instability of her knee, but she had a pretty good story of pain with walking. And so in 2018, she had an MRI scan that showed that she had a meniscus tear. And because she didn't have any meniscal symptoms, I asked her to go along to the GLAD program at one of the local physiotherapy units. And she did that. She then represented in 2024, and she represented with a new MRI scan. And the MRI scan was reported with a number of findings, but in the summary findings, we had tricompartmental osteoarthritis and a macerated meniscus tear. And so using that as a diagnostic investigation, one of the things that we see a lot of the time in our referrals for knee pain are patients of an appropriate age with an appropriate degenerative history profile and appropriate degenerative signs and symptoms coming with an MRI scan as their first investigation. And I suspect that there is an enormous sway of public and patient pressure coming into the primary healthcare setting, where the first words out of their mouth would be, I've got a painful knee, I want an MRI scan. And then it comes down to the public health economics of that as a sensible thing to do. And so within this second quality statement, the emphasis very much is that if you're taking a history and examining the patient, you still can make osteoarthritis as a clinical diagnosis. And that if you want to move to an investigation, the first investigation, if you as the clinician think that this is an osteoarthritic knee, the first investigation should be a weight-bearing x-ray. And so we have these recommendations in the standard point. You can make a diagnosis of osteoarthritis on the basis of the history. The symptoms that patients have don't always match the scans, and that can be a reason not to do an MRI scan. If you go looking with a very sensitive investigation, you'll find something. And it might have been there 18 months ago with no symptoms at all. There's no good correlation. And x-rays with the patient standing are the first thing to do. And there's also a recommendation for radiologists within the clinical standard recommendation. That's when you send the MRI scan, you should ask a specific question. They are supposed to answer your specific question for what you think the diagnosis is. And then they should report all of the other ancillary findings on the scan to a hierarchy of importance. And very clearly in this document, osteoarthritis should be at the top of that, with any mention of a meniscus tear lower down. And oftentimes the patient comes in and I say, I'm Andrew Wilkinson, how can I help you? I have a meniscus tear. And it takes sort of 10 to 15 minutes to unpack the fact that they have an osteoarthritic knee and the meniscus tear on the MRI scan is secondary. So if we then move to the same patient with the weight-bearing x-rays, I think you can all clearly see the difference between the left and the right knees, and the medial compartment of the right knee hasn't got any cartilage left between the two bones. And one of the other things I would encourage you, and I encourage the radiology staff as well when I get to meet them, avoid the use of subjective terms when you talk about radiographic findings. Your interpretation of mild, moderate, or severe may not be the same as mine. It may not be the same as the patient's, and it's probably not the same as the radiologist's. And there's a very good classification system for osteoarthritis of the knee. That's the Kelger-Lawrence system. And it's it becomes an objective way of talking about, well, your knee shows that you have 50% or 100% narrowing of the joint space and you have some element of sclerosis. It's a very good way of taking the emotive aspect out of a subjective topic. So we know from our clinical experience, from the patients that we meet, that symptoms don't match the scans. There's an enormous difference between pathology and symptoms if you compare metropolitan centres to the rural regional settings, who seem to have a really significant increase in their resilience and ability to cope and present with very severe pathology, and they've battled on for a very long time. But if we try and dig into that, why is there such a difference between the pathology on the scan and the symptoms that the patients present?
And this comes down to quite a simple answer, which also gets more complex the more you dive into it. The iceberg analogy works quite well here. Above the surface, we have a patient's symptoms, we have their pain, we have their stiffness, and we have their decrease in function. And we also have their radiological findings, but we already know those two things don't correlate. The reason they don't correlate is because of the mitigating factors below the waterline. So the things that are below the surface. The first one I want to talk about is about the muscular changes that happen as a result of knee OA. So we know from a pathological level that knee OA is a disease of the joint. It affects the cartilage, it affects the synovium, and it causes swelling, and it causes joint pain. This joint pain, however, has secondary knock-on effects to the muscles that surround that joint. The body's natural response to pain is to inhibit the stabilizing muscles around the knee and to cause the person to change their movement patterns to offload the sensitive structures. They could develop a limp, they'll start going upstairs leading with the other leg. They'll do everything they can to stop loading up that joint and stop using the muscles. The effect of this is we get a loss of strength in those muscles, and over time, we get atrophy of the muscles as well, so there's muscle wasting. The consequence of this is the knee joint becomes a little bit less stable, it becomes a little bit less able to tolerate the loads that are placed onto it. So increased load is transmitted to the joint itself and onto the already sensitized cartilage, leading to more pain and restarting the cycle again. So muscle inhibition and muscle weakness, or those muscle changes, are the first port of call here. But the secondary effects of that are patients are able to do less. Their physical activity decreases, their independence decreases. So the lack of physical activity leads to altered body composition, increased metabolic stress on the system. Their decreased independence leads to social isolation, leads to mental health deterioration and altered pain and beliefs and behaviours. All of these symptoms, this cascade of effects, all lead back to the symptoms they experience. They lead back to pain, stiffness, and decreased function. Yet they have very little effect on the actual radiological changes or the findings that you see on imaging. So this is why we can't just treat osteoarthritic patients as a joint condition. We have to consider the whole picture and put it into the context of that initial assessment.
So when we get to this person back to case 2, we have the weight-bearing x-rays, and one of the crucial factors for me is when I get to these people and I say, look, your diagnosis is not a meniscus tear, you've got arthritis. We talk about the x-rays, we show the complete loss of joint space. They know already that they have a change in shape to the leg because they're looking at it in the mirror. But this person didn't want a knee replacement. So then what's the appropriate thing to do? What is appropriate conservative management of a person with a proper diagnosis and proper pathology and some level of pain and disability? And so I am very, very much a fan and encourage people to go to a strength program under supervision. And here I've got access to a few of those, and Kaiser is one that I'm a big fan of. So I've referred this lady in to see the team at Kaiser for her knee osteoarthritis and pain.
So before I talk too much about the case study and what happened to this lady once she presented to us, I want to step back a bit and explain a little bit about muscle anatomy and the propensity of our muscles to naturally deteriorate over our lifespan. So with the aid of the graph, I'll talk you through that first. In our early life, our strength increases via the activities we do. Every hobby we have, every sport we play, every life choice we make leads to our strength growing over time. This is like investing the super fund for our ongoing health. We build up our strength in our early years. We build a nice healthy set of muscles. Here we've got a cross section of thigh muscles. As we pass the age of 30, we begin to lose that muscle strength if we're not doing any structured form of strength training. So from the age of 30 onwards, we lose between 3 to 8% of our muscle strength per decade. This accelerates as we hit our 50s and 60s, up to about 3% year on year. So you can see quite quickly, we move from this point in our 30s, where we sat a long way above this dashed horizontal line on the graph, which represents a disability threshold. We descend down to this disability threshold. In this case, disability threshold could represent the time that a patient will need a total knee replacement. They've lost strength, they're unable to do the things they want to do, and increasingly their knee joint is causing them pain in the activities they do on a daily basis. The good news is we can have an effect on this strength. By implementing a structured strength and conditioning program, it's possible to slow the rate of decline and even in some circumstances reverse those changes so we get an increase in strength compared to how it was. If you look at the two MRI cross sections on the right hand side here, these are both from a 70-year-old. The one at the bottom shows the natural decline of the muscle mass in the middle. The one above shows how muscle mass can be maintained if you are following a structured strength program. So with these patients, we can effectively increase their longevity before they need to make that decision or have that desire to have a total knee replacement. And the good news is it's never too late to start. Large cohort studies conducted in clinics across Europe show that if we start strength training in our 30s, in our 50s, or in our 70s, we have very much the same effect. We see great increases in strength early on, which then slow down over time. But we have the ability to all build strength at any point in our lives, regardless of pain or pathology. So coming back to our case study, on first look, it sounds like she's had a fairly robust conservative management program. She's been walking for up to 20 minutes a day, but she has found that has started to exacerbate her symptoms. She tried hydrotherapy, she tried aquarobics, but found that it didn't really change her pain levels or change her function. She's completed the GLAD program, as Andrew said, but found diminishing returns from the ongoing exercises, so stopped doing them. And she still, to the point of time when she was referred to KEJA, was still doing a combined Pilates and yoga class once a week to try and maintain her strength. But still, her pain and her symptoms continued to regress. And when we look specifically at OA, we know from evidence that's been around for the last 30 years that there's an inverse relationship between knee OA and the size and strength of the quadricep muscles. We also know that the most effective way to strengthen the quadricep muscles is through progressive resistance training. And this strengthening of the quadricep muscles can reduce pain and improve function in an osteoarthritic population. Increasingly, more recently, we've also found that muscle balance is important in this population, with the ratio between quad and hamstring strength being a big mitigator in the need for total knee replacements. So coming back to our case study too, the one thing missing from her conservative management plan this far was actually structured resistance and strength training, which was intense enough to change the physiology of the muscles in the thigh themselves. And this comes down to dosage. Dosage is really important in the same way of medication. It's really important when you're prescribing strength. From an intensity point of view, we need to have it targeted to specific muscle groups so we can address those imbalances that might be developing between quads and hamstrings. We need it to be at an appropriate level so that it stimulates hypertrophy in the muscles. We need it to be able to overload the muscles to produce this compensation effect. We need our patients to be working through full or as near full range of motion as they can. And it needs to be isolated enough so that we can prevent compensation. As a population, as a species, we're very good at finding the path of least resistance to movement. And if we can do a movement using our glutes instead of our quads, or our hamstrings or our calves instead of our quad muscles, we will. The last important thing we need it to be is progressive. And this is why a lot of exercise programs fail, is because patients don't progress their resistance over time. So where they get their initial strength gains, proportionally the weight they're moving lowers in resistance, and they aren't then able to stimulate that hypertrophy by getting the overload effect on muscles. So it's got to be a progressive resistance program as well. Frequency of strength training, it doesn't have to be done every day. It doesn't have to be done that frequently. Studies show that once, twice, or 3 times a week can be effective, and the optimum being around that twice a week block. Consecutive days of training aren't in fact recommended if you're loading the muscles with sufficient intensity, because you need that recovery time. You don't actually get stronger when you're moving the weight, you get stronger in the time that the muscle recovers afterwards. The third thing about dosage is there's minimal dosage for physiological change in the muscles is about 6 weeks. Patients will get stronger before that, but these are neuromuscular changes. There's no physiological change in the muscle until around the 6-week mark. And depressingly, strength loss occurs within 7 days of stopping a resistance training program. So it is something that these patients need to continue long term. And despite all the evidence and despite the recommendations, the uptake of conservative management is poor. 25% of Australians with OA do a form of exercise, but only 14% do any structured, progressive, correctly dosed resistance strength training. 33% of patients on public wait lists have not engaged with conservative interventions at all, whilst 83% take regular medication, and often opioids. But the landscape is changing, and it's changing because funding is changing, and funding is changing from a fairly unlikely source. It's changing more from the private sector than the public sector. GLAD programs are now being established, which you can get rebates on from private health insurers. And as of just this year, all of the private health insurers in the box below have started funding private hospital avoidance knee osteoarthritis programs through KESA. So what that means is clients who are insured through any of these private health companies can access a gym and complete a progressive resistance training program for 26 weeks with no out-of-pocket charge, which is funded via their hospital cover, which is a groundbreaking thing for private health insurers to be proactive in this space. So there is light on the horizon. And the results initially are looking good. So from these programs, we're seeing that we can have significant improvements in strength of the lower limb muscle groups, quads, hamstrings, and glutes. We see on average a 37% decrease in pain levels across the population, and we're seeing associated improvements in function as well. When we look at our case study, bearing in mind this was an already active individual, she started strength training, and within 6 months, she's seen a doubling of her ability to move resistance through leg extension, so her quad muscles, and she's seen a doubling in her weight on leg press within a 6-month period for someone who was already doing a conservative management program. And for her as well, we've seen improvements in visual analog score. Has come down from between 5 and 7 to 1 and 2 as an average over a 4-week period. Her KU score has decreased. Her walking tolerance has now improved to the point that she has just booked a walking trip to Cradle Mountain in Tasmania, and she's up and down stairs and sitting to standing pain-free. She reports that there's a 90% improvement in her symptoms. She's continuing with strength training, and she has no intention of pursuing a total knee replacement anytime soon.
So that's the first patient you've done me out of a job with. That's good. So that's really interesting for me to know that. And if you cast your mind back to the graph of the different ages of improvement, that graph was measured in weeks of time up to 200 weeks. This is not a fast process. So if you move then on to the right time for referral, we've got a 64-year-old lady, and her main complaint is not actually of pain. This is an interesting phenomenon to try and tease out. The patients don't come in and say, I have a pain profile that's in keeping with osteoarthritis. They come in and present their difficulties. So her problem was stiffness. On the right side, she had some episodes of the knee feeling wobbly or giving way. She hadn't actually fallen down because of it, but she was still playing tennis 3 times a week. She didn't have any difficulty sleeping, and that's an important indicator of pain central sensitization. And crucially, again, for this lady, although she had all these difficulties, her overarching ambition was to not have an operation if she didn't absolutely have to have one. So we can take someone like this who's clearly very motivated and active and not having huge amounts of pain. One of the things that I would say to you is the people who are disturbed in their sleep on a regular basis by their osteoarthritis want anything to make it go away, because it drives them really quite mad, and I can understand that. So in this case in particular, because of the lack of central sensitization, there's a really good option for education and self-management of an established diagnosis. And again, when you look at the wording of the statement, this comes into a holistic approach to the entire patient. So we can, this person now can leave the office with some information about how to safely manage their arthritis. You can help them to accept that and to tailor a management. And that may be for the tennis player, well, take some painkillers before you play, get yourself an ice pack or an ice sleeve or a recovery device for afterwards. And if your knee feels wobbly when you play with a brace. If the 10-minute session that you get to do your holistic entire patient care episode isn't long enough, there are plenty of allied health professionals and other clinicians or services to help the patient with their education and self-management. And if the patient isn't enthusiastic about an operation, but wants to investigate that and explore what does an operation involve, there's definitely an educational role to be provided by the orthopaedic surgeon. And hopefully your well-balanced local orthopaedic surgeon can do a better job of that than the patient can with the doctor Google research. And that this patient then, as well as feeding into quality statement 3, she's a really good example of the level of physical activity that one can continue to have with an established diagnosis of osteoarthritis, and that can be improved and maintained with appropriate conservative management. I have numerous patients who have come with the same scenario. They have an established diagnosis of osteoarthritis. That's what they've been told by their primary healthcare physician, and all their friends and family all have a knee replacement. It's a great thing to have, but they don't want it. And with appropriate education and the use of Nordic trekking poles and appropriate management and sensible, judicious use of painkillers and anti-inflammatories, they can maintain a very high level of activity and maintain the exercise that they want to do. We have an understanding now, and this has really been a bit of a seed change in the orthopedic community and general health community as well. General activity and exercise in the patient with established osteoarthritis doesn't make their arthritis worse. If we take the knee as a special example, because we have multiple compartments, the most common pattern of osteoarthritis in the Western world is medial compartment isolated disease. That means that you have patellofemoral joint cartilage and lateral compartment cartilage that also needs to be maintained. Cartilage has no blood supply. It maintains its nourishment and health through a process of regular compression and relaxation. And if you take somebody who's got an arthritic knee and they don't do anything, the rest of the cartilage in the knee is much more affected by the disease process than if you can find a way and help them to find a way to protect the remaining cartilage, as well as all the muscular benefits and the stability benefits that Rob talked about for our previous case. So for this person who's already playing tennis, there's an ability for appropriate conservative treatment, education, and self-management to allow them not only to continue playing tennis, but to increase their strength, which will probably improve their symptoms. I don't promise anybody that this treatment will improve their tennis game or their golf game if they play golf, but it can make them more comfortable doing it and give them less instability and better symptom control. And this is very much a thing that we're pushing on the surgical side too. Arthritis is not a barrier to exercise. Early arthritis is not a barrier to running. All of these things can be done, and if it's in the patient's goals, it can also be done without an operation. Some would say that's heresy from a surgeon, but that's okay. Then we can move on, and this is another case of mine. This was a challenging interaction at the first level. This lady was pushed in by an extended family member in a wheelchair. She had a previous successful left knee replacement and was scheduled to have a staged knee replacement over a few months. But after her first knee replacement, she got COVID. And she was very badly affected by post-viral fatigue and some really proper and quite significant interstitial lung disease with a significant period of time in the intensive care unit, and then specialist management by a pulmonary physician. She was obese as a class 3 obese person, and as well as her comorbidities, as you've heard, and being wheelchair bound, she also had significant psychiatric difficulty and was depressed at the time. And so if we look at the care standards we've had so far, looking at the whole picture, the first thing I said to this, very unfortunately, was there was absolutely no way that I would entertain the suggestion of a knee replacement if she was still in the wheelchair. And so there's an element here of saying that in some people, the knee replacement is very definitely a harmful thing if they're not in the right space to do it. I'm in the very fortunate position up in Geelong that I've got some good contacts with rehabilitation specialists, and I contacted one who I work with quite closely. He was able to get this lady into hospital for a couple of weeks of rehabilitation in the physiotherapy gym at one of the hospitals. And when she came back to see me again, she was coming in by herself with a 4-wheel frame and had lifted a lot of her depression. She still had interstitial lung disease, which was classified as stable by her specialist. She was still obese, but I felt she had shown a lot of grit and resilience and determination in coming back by herself without the wheelchair. So after 2 weeks in rehab, when she represented, we did some digging and double checked. with her lung specialist that there was nothing to be done to improve her respiratory function. And with some element of trepidation, I went ahead with the knee replacement, and some of the trepidation you've heard about, and some is apparent on the screen if you look at the distance that it would take me to get from her cutaneous border all the way down to the center of her knee joint. These are challenging knees to make judgments on. They're challenging knees to operate on at a technical level. And there are really genuine concerns about obesity in joint replacement. So we have the relationship between obesity and osteoarthritis. This is from a national survey in Australia, and there's a newer version of this published, but the 2012 study is still relevant. And I don't think this was you as the author, Rob, was it? R.X. Osborne at the bottom?
Wasn't me. No, not this one.
The odds ratio for getting osteoarthritis if you're overweight is 2.1 compared to being of normal weight. And it's interesting now in the National Joint Registry that I'll talk to in a minute, it's now not overweight, it's pre-obese. The odds ratio for developing osteoarthritis of the knee, if you have obesity, depending on your class of obesity, is between 5.5 and 7.3 times the normal weight population. So in terms of a causative factor, if you could fix obesity, you'd be on a winner. And then there's obesity and joint replacement. This is a much more difficult area. The graph that you have on the left-hand side is from the 2024 Australian Orthopaedic Association National Joint Registry. It's a freely available document to download from the AOA website. And if we're looking at what's the best line to be for this, you want to be the lowest curve. You want to be the blue curve of normal weight with BMI between 18.5 and 25. And that is a Kaplan-Meier survivorship curve for how long your knee will last for the number of years after you've had it done. And if you're in the pale yellow line of obese class 3, you have double the risk of revision at the 7 or 8 year mark as you do if you're a normal weight. One of the reasons this is a difficult area is obese patients are more at risk of needing their knee done again. They're more at risk of it falling out, but they gain just as much benefit from having it done. So there's a fine ethical line between managing the problem, helping the person, and denying reasonable care because it might cause a difficulty later. And the difficulty that we have in particular is that if we look at the relationship between obesity and revision, if you're in the bottom right-hand quadrant of the graph as obese class 3 over a BMI of 40, the revision cause becomes important because you have a significant increase in the risk of revision for infection. And infected prosthetic joint replacements are a really genuinely life-altering phenomenon. One of the infectious disease consultants that I work with had described it to the patients who are at the beginning of their journey. This is worse than having chemotherapy for cancer. And this really is a devastating journey if you have a knee revision for infection. So we do have really big concerns about obesity and arthritis and about obesity and joint replacement. And this is in the Care Standard Review, Quality Statement 5 about weight management and nutrition. And there's a few really big things on this, and it's not just all about popping pills. And I think the dietitian world is changing in terms of their thinking about these people, because a lot of these folks need help. The primary objective, though, should be to lose weight and improve body composition. I'll come back to that in a moment. Body mass index, as much as it's easy to use and commonly used, it's not a great indicator of body composition. So if you look at the bodybuilding world or the strongman world, it's not necessarily a recommendation for health, but most bodybuilders are obese according to body mass index, but they have very low percentage body fat, they have very high percentage muscle mass, they have very good bone density. It's not perfect. We know from the discussion earlier on that we have a sarcopenic progression over our life after the peak, and loss of muscle mass is detrimental to the progression of osteoarthritis, but maybe more accurately, progression of the symptoms for osteoarthritis. And we need to maintain muscle mass. So one of the things that we're learning about the new drugs that are assisting with weight loss, and there are more on the market now than there were, but it seems to be that the initial weight loss with some of the medications designed for diabetes management and weight loss are loss of lean body mass in the initial period. And there may be an aspect of that that also occurs in the early period of bariatric surgery, patients who are dangerously obese who have some kind of procedure. The early loss of weight is probably lean body mass, later followed by adipose tissue loss. But lean body mass loss is a bad thing. And we now know that within the orthopedic community. The studies are coming out on a repeated basis that patients who are still in a catabolic state after a bariatric operation have enormously higher perioperative and postoperative complication rates than the obese person would have had. So this is a multifaceted and complex area, but also of utmost importance.
And I guess that brings us to case study 5, and I'd like to just have in the record book that it's not a one-way street for referrals from Andrew to me. I do also refer some back the other way. And case study 5 is an example of what happens when clinical care standards are followed, and the results you can get from patients when they do have the right patient having the right intervention at the right time. So this was a 78-year-old female. She'd received a diagnosis of knee osteoarthritis via her GP purely through a clinical diagnosis without x-rays, without MRIs, or without any form of imaging. And the primary intervention of the GP was to refer to physiotherapy at Keyser. We also had a referral at the same time from her osteopath, who was very much of the opinion that he was doing all he could from a mobility and from a joint health point of view, but the person required more strength. The aim of the patient was to avoid a total knee replacement or to improve the outcomes. And this came from a fear brought about by the experience of her husband, who'd had two previous knee replacements, bilateral knee replacements, and ended up with very stiff knee joints, which really limited his function and the ability to interact with his grandkids. So this patient had 7 grandchildren, and part of her love at the time was to play with them, and that involved getting up and down off the floor. So this patient commenced treatment at Keyser. She, similar to the patient we talked about before, commenced an independent strength training program. And she started this journey in 2015. Over the next 9 years, she saw some significant improvements in her knee function and her knee strength. She got to the point where she was functioning pretty well up until 2023, when things started to deteriorate. We started to see an increase in her pain levels, a slight decrease in function, and some valgus deformity at her right knee joint, which was having secondary implications with glute med tendinopathy, where her Q angles had changed, and she was getting a lot more hip pain. In ongoing consultation with her GP, it was decided that we'd given conservative management as much time as we felt we could, and she was probably at the stage now where she needed some kind of escalation of treatment. So the GP referred for x-rays. Do you want to talk through the x-rays, Andrew?
Yeah. So these are the Rosenberg view. You can see that on the screen. So these are weight-bearing x-rays, and the Rosenberg x-ray is done with the knee slightly flexed, about 30 degrees. It's why you get a subtle change to the notch. And the big differences here are in the lateral compartment, comparing the right to the left. With this particular lady, you can actually see that the femoral condyle on the right has dipped below the level of the tibial plateau. So this has got a really significant erosion of the lateral compartment. And it's not a bit of wonder that she had significant valgus deformity. She's also got significant sclerosis and some osteophytes. And in this case, the osteophytes are fairly minimal and mostly confined to the lateral compartment.
How long would you expect a progression of NEOA to get to that stage? Are these acute changes?
It's a really interesting question. For most people who present with a sclerotic osteoarthritic type knee, these are slow progressions. For most. Occasionally we will meet somebody who has an enormously rapid progression from normal to almost collapsed and crumbled. And that's usually some form of poorly understood inflammatory type osteoarthritis. So it's referred to in the hip as a rapidly progressive osteoarthritis. I suspect there's something around a transient osteoporosis and insufficiency fracture of the non-overloaded, non-conditioned bone that just can't stand up to the increased stress of an osteoarthritis. But these changes for this really are likely to have progressed slowly over a number of years.
So off the back of these x-rays, and not just the x-rays, but the symptoms and the progression of symptoms for the patient, I referred on to Andrew, and the result was?
These patients, when they present in the rooms, when the history is, I've had knee arthritis for 9 years, I've seen an osteopath, and I'm in a strength program currently, and I've had a phone call from the person running the strength program, it's very quickly onto, well, let me have a quick look at your knee. Yes, that's very bad. Would you like a knee replacement? And if they say yes, the only question is, when would you like it? It's a brilliant example of, if all the ducks are in a row, it's one consult, the risks and processes of the knee replacement can be explained very clearly because all the education and self-management has already happened, and we can move really quite quickly onto a definitive treatment because it's become very clear at that point that that's what's required.
So from a progress, robotic assisted knee arthroplasty was performed in January 2024. A 4-week review, she had fantastic range of motion, full extension and 120 degrees flexion. She returned to strength training at just 4 weeks post-op. And at 6 weeks, her range of motion was up to 140 degrees flexion and full extension. This patient was over the moon because her husband had struggled so much with his joint range and his recovery after his initial surgery. Her strength returned to pre-operative levels. So you can see here on the left-hand side of the graph is May 2020, when her strength started to decrease and we switched her to single leg training through here. This was the point at which she had a knee replacement around Jan-Feb 2024. And you can see the rapid improvement in her strength. And by the time we hit October, so this month, last month, she's actually stronger then than she was back in 2020 as a result of having the knee on. Leg press, you can see a similar pattern. Here, from 2021 onwards, she actually continued to improve in strength up until December of 2023, when she was finding it a little bit more challenging to do the leg press. She had the operation, and then straight away, you've seen these automatic improvements, and she's now back up to the level she was before, at just 6 months post-operative. So the other consideration with these patients is the effect that pre-operative strength has on patient outcomes after a knee replacement. And the evidence behind this has always been slightly weak. And the reason for that is because many of the previous systematic reviews compared all exercise interventions to recovery times. This review from 2022 narrowed down the focus a little bit and looked purely at resistance training prior to, in this case, hip and knee replacements, looking at post-operative recovery and functional performance. And when you separated effective resistance training from all other exercise interventions, they found that from a strength improvement point of view, there were moderate to large improvements at 3 months post-operatively. And these improvements continued with small to moderate effects at 12 months. And from a patient-reported outcomes point of view, there were small to moderate effects at 3 months and no difference at 12 months. A lot stronger evidence than there'd ever been with the pooled effect of all exercises.
So finishing on the last case, there's an opportunity to talk about the updates on surgery. And we probably can make that relatively brief. There are lots and lots of things to talk about around knee replacements. I could entertain you for hours at a time about the nuances of what we think may be right or maybe not right. As with so many things in life, there isn't really very much new under the sun. Everything is a reinvention of something that's already been thought about. And the short answer is, the summary answer for this is, there's not much that's really new over the last 20 years. Doesn't mean we're not getting better at doing them. So we'll cover a couple of small things quickly. Cement versus no cement. This is an idea that biological fixation may be better than the bone cement we've been using since the 1960s. This is, I think, primarily a push on the part of the companies and on surgeons who may want to operate faster. The components without the use of cement are much more expensive. If we look at a health economics perspective, they are twice as expensive as a traditional cemented implant. They're not much better, and depending on the metric that you apply, they may not be better at all at a population level. There are some smaller nuanced areas. Perhaps the class 3 and class 4 obese patient with a well-functioning cement-less component might have longer survivorship, but that is a small market. Partial knee replacement versus total knee replacement. Is there anything new? This is an old argument. It is a circular argument, and it goes around in waves of enthusiasm, and then it dies back a little bit. It has maintained a small minority case. There's been a resurgence of interest in it with robotic assistance. If we look at the absolute numbers, and these are numbers taken from the National Joint Registry, and kudos to the Australian Orthopaedic Association. The Australian Joint Registry was the first established national joint registry in the world. The number of partial knee replacements performed in 2003 was a little over 4,100. And in 2023, that number has gone down to about 3,500. If you look at the total knee replacement burden, we have more than tripled that as a yearly figure, with 68, nearly 69,000 cases done in 2023. So that is still a very small select group of patients who are suitable for partial knee replacement, even if we think that putting it in with robotic control might be better. That brings us on to robots versus the expert surgeon. There isn't really any doubt in the literature that's available or in the joint registry that since about 2016 and the emergence of successful robotic technology, that the numbers are increasing. And those trajectories are set to mean that by the time you get probably to 2030, there'll be more robotically assisted knees in Australia than expert surgeon knees, if you like. Is it making any difference? There's a number of ways that we can look at difference. Some of those are about patient-reported outcomes. Some of those are about what the surgeon thinks. There's a bit of a placebo effect in all of that. And then there's the binary, well, does it last any better? The summary answer from the National Registry report in 24 has been that there is no difference in survivorship, that all knees fail at approximately the same rate. I think we will start to see an emerging difference. We're not there yet, but these two graphs taken from that National Joint Registry report show the difference in the reasons for failure. And again, we're coming back to the reason for failure being important, back to the BMI class 3 obese person with the infection. The infection failure rate for robotically assisted and not technology assisted or expert surgeon, if you like, the infection rate is the same. If we look at the non-technology assisted graph on the right-hand side, loosening as the green line, is clearly the second leading cause. And it disappears into the rest of the data for the robotically assisted. And one of the difficulties we have in assessing success of arthroplasty is that modern joint replacements probably will last for 7 to 10 years, even if they're not that fantastic. It's 15 to 20 years we're going to make a really big difference. So I wouldn't be surprised if in another 8 years, we start to see that robotic assisted surgery is making a difference. Absolutely categorically at the moment, I don't tell patients that it's better. What do we think about age and knee replacement? If I've said that most knees will last really well 7 to 10, we still definitely would prefer to operate on the older patient. If we look at the characteristics of the people who are most likely to need to have their knee done again in a 10-year period or a 15-year period, it's the under 55s. And if you really narrow it down, it's men under 55. Men under 55 are really likely to have a knee replacement again within 14 or 15 years. There may be an artifact of survivorship because that's how a Kaplan-Meier curve works, but we still have a reluctance about knee replacement in the young working population. As I've said previously, there are no published randomized studies that say that the patients derive significant outcome benefit from a robotic assisted joint replacement. At a personal level, I love doing them. I think it's a great thing to do. And that feeds into why we have increasing numbers. I can talk about the Geelong experience. In Geelong now, we have a robot in every hospital. We have 3 robots at the Epworth and 3 at St. John's and 1 at the public. And we can use that to understand the surgical interest in it, the potential that it might have that we haven't proven yet, and the increasing numbers of robotic assisted cases. So what are we doing differently? Is there anything different in the last 30 years? Well, it depends a bit on your time frame. So the first robotic assisted hip replacement was done in 1992 and has more than 2,000 cases published. The first navigated assisted knee replacement was done in Grenoble in France in 1998. We might say that enhanced early recovery, getting home within a day or 2 of your joint replacement, is a new thing. David Mitchell in Ballarat's been doing that for many years with great success, and we're doing it again at the Geelong University Hospital, getting patients with hip replacement out after a day and knee replacements out after 2. I think what we are doing better is we're understanding the role of activity. We're getting people out of bed faster. We're pushing people harder in their recovery. And to help them with that, we're using a lot more multimodal microdosing of analgesia to get them up and get them going. And I think that getting up and getting going quickly after joint replacement is one of the reasons that we've seen a really significant decrease in the perioperative complication rate around knee replacement surgery.
Yeah. So to summarize the care standards in one slide, I guess, the decisions for a care pathway for patients always have to come from your comprehensive assessment. And follow on from this need to have timely reviews because patient situations change, just like the case study 5. Everyone is appropriate for conservative management. And the conservative management has to involve a degree of education on self-management. It has to involve exercise, including, really importantly, progressive resistance training or strength training. And it should include weight management and nutrition advice for those that need it. Most people will be appropriate for pain relief at some point in their OA pathway. It should be used to manage pain. It should be used to reduce pain that allows them to maintain their mobility. The pain relief of choice should not be opioids, and the provision of pain relief should be on an ad hoc basis. It shouldn't be a set and forget. It should be reviewed regularly to make sure it's still appropriate for that patient's needs. Imaging is not routine for diagnosis of hip OA. X-ray, when clinically warranted, is the imaging of choice. And this is only for people where you feel that there may be a need to escalate their care to surgery. MRI, CT, and ultrasound scans are inappropriate for the diagnosis of knee OA. And then it comes to joint replacements. These are appropriate for a proportion of the population, and people do recover very well from knee replacement surgeries. But it has to be reserved for those who have a diagnosis of knee OA, have severe functional impairment and ongoing pain. Importantly, those things despite optimized conservative management in the short term. That just about wraps us up from the presentation side of things. If anyone's got any questions.
There is a couple of questions from the audience. Do you do tele rehab for rural patients who cannot get to see physios or docs or distance, remote with sensors?
Tele rehab is an interesting one. The evidence behind the efficacy of tele rehab is pretty poor, and I understand there's some real geographic barriers to getting these services rolled out. It's definitely an option. Increasingly the issue we have with telehealth services is compliance and adherence to a exercise program. So from a physio side of things, I would much prefer that there was a local physiotherapist or a gym with personal trainers that you could trust, who you could refer patients to from a strength point of view. Andrew, do you do telehealth?
I'm very happy to do telehealth. I can't do telehealth rehab. But yeah, I've got a couple of different platforms for telehealth for consulting and review of patients in the Western districts if required.
Thank you. Patients who have issues with ongoing knee swelling, inflammatory phenotype, are particularly difficult to manage. Their swelling often inhibits their capacity to exercise. Any suggestions, bearing in mind that many of these people can take anti-inflammatories?
So I can or cannot take anti-inflammatories?
It's in the chat box there. Sorry, what was that?
Just trying to clarify if they could take non-steroidals or couldn't take non-steroidals. Yeah, can't. That's a slightly difficult one. It depends then a little bit on the nuance. If you have someone that you think inflammation is the primary driver of the problem, then you could certainly trial them with a period of steroid injections or oral steroids for a brief period to confirm your hypothesis. And then it may well be that if they are not in a position to have a replacement and they can't, because of their swelling, they can't complete an exercise program, because we understand there's a genuine inhibition of muscle function with an inflamed joint. They may be suitable for a little bit of rheumatological, especially depending on whether you've got access to that. But I absolutely agree. The patient with the recurring tense effusion in the knee is a challenge. It may well be that a series of steroid injections closely applied can be of benefit, understanding that there are also risks with that as a treatment regime.
Do you have a good video or handout we can provide for patients?
I have a number of handouts around conditions and specifically around the frequently asked questions for knee replacement. It's probably easier if I see or talk to the patient remotely to give them information. I don't have a generic how to manage your osteoarthritis handout.
Could you comment on the use of injectables, i.e. cortisones, PRP?
So steroid injections have come up there just with the particularly inflamed joint. I think that should be reserved for the tense effusion. The clinical care standard makes a comment on some injectables. The recent reviews that we've done at a specialty level in my group practice have suggested that the evidence is really quite poor for everything, including steroids. Our recommendation at a group practice level is not to use PRP or hyaluronic acid or any of the various combinations of those two that are now emerging on the market. They don't have any significant evidence base. They're an expensive treatment that really doesn't change the disease process. And I would only speak more negatively about stem cells than I could about PRP and Durolane.
Thank you. I don't have any more questions. We've got a couple of minutes. If anybody wants to take themselves off mute and ask a question, please do so. Otherwise, there's the evaluation summary survey. If you could click on that link and give us your feedback. We do intend to do some more orthopaedic updates in 2025. So if you want any topics, just pop them in that evaluation survey and we'll see if we can put them into our calendar. And thank you very much to Andrew and Rob. Great presentation, great information. And I'm sure we'll have you back at one of our other webinars. So thank you everybody for attending. And if there's no more questions, I'll end the webinar. Thank you all. Bye.
Thank you. Bye-bye.